Hello, warm welcome to today's talk. Now, today's topic could not be more serious. It's the amount of people that died during the COVID pandemic as a result of the intervention of nurses and doctors giving them morphine and midazolam. Over the years, I've come to the firmer and firmer conclusion that this is a complete national outrage that is largely being ignored. Now, I'm going to be giving information from this paper here that we actually looked at last year. But the sad thing is that just nothing seems to have been done. This is Wilson Sy, Excess Deaths in the United Kingdom, Midazolam and Euthanasia in the COVID-19 Pandemic. It's an excellent paper. You can download the PDF there. It is quite statistical in nature, and I make no pretense to be the world's best statistician by any means. But I'm going to try and give you a sort of a simplified version of it that makes sense. And it's got tremendous impact. And just before we do that, to decide if you want to watch, let me just give you something of the nature of what we're going to be talking about. So United Kingdom, midazolam injections lead 1 month. So what happens is, this is actually a month. So what they've done here is they've taken the amount of injections shipped out, and then looked at the deaths the following month. And that makes sense because it would take time for the medicines to get into the care homes. Then the doctors would have to prescribe it, very often over the phone, looking at patients over the phone. And then the nurses would use their discretion as to when to give it. Great failures, we could argue, in all of these services. Not attributing malice to any individuals, not by any means, but we'll see the systemic failures that took place. But this graph here shows this. So what we have here is UK monthly excess deaths. So the red line is the excess deaths. And when you put that line back by a month, you see it overlaps pretty well perfectly the midazolam monthly injections, 1,000 per month. So we see precise correlations here between the shipping out of midazolam and the deaths. And the correlation there is plus 91%. So that's kind of what this is about. Let me just read you a few bits from the abstract of this paper. Macro data during the COVID-19 pandemic in the United Kingdom are shown to have significant data abnormalities and inconsistencies with existing explanations. So looking at the big data, like the amount of midazolam shipped out, the amount of people that died, that big data is not really reflected in the official explanations of excess deaths. This paper shows that the UK spike in deaths wrongly attributed to COVID-19 in April 2020 was not due to SARS-CoV-2 virus, which was largely absent in April 2020, but was due to widespread use of midazolam injections, which was statistically very highly correlated, coefficient over 90%, as we've seen, 91%, with excess deaths in all regions of England during 2020. Importantly, excess deaths remained elevated following mass vaccination in 2021. So the mass vaccination did not bring the death rates down dramatically, but were statistically uncorrelated to COVID injections. So the deaths were statistically uncorrelated with the vaccine injections, while remaining significantly correlated to midazolam injections. There's the evidence. That correlation is very, very tight. Very alarming, very alarming implications of this work for friends and relatives of yours that are no longer with us. The widespread and persistent use of midazolam in the United Kingdom suggests a possible policy of systemic euthanasia. Direct quotes from the paper. Unlike Australia, where assessing the statistical impact of COVID injections on excess death is relatively straightforward, the UK excess deaths were closely associated with the use of midazolam and other medical interventions. and indeed you could argue the lack of medical intervention such as antibiotics and oxygen. The other main medical intervention there, of course, is morphine, because morphine and midazolam both depress respirations and can stop people breathing. The iatrogenic pandemic in the UK was caused by euthanasia deaths from midazolam and also likely caused by COVID injections, according to this paper. But their relative impacts are difficult to measure from the data due to causal proximity of euthanasia. In other words, because sometimes the vaccines and the midazolam were given at the same time, it's hard to tell which deaths were from which. Do read this paper. It is a very intelligible paper once you get past some of the numbers, but the graphs are really straightforward. Global investigations of COVID-19 epidemiology based on the relative impacts of COVID disease and vaccination may be inaccurate due to the neglect of significant co-founding factors in some countries. So not only has this got applicability to the United Kingdom, it's got much wider applicability as well. Let's look at some more of these graphs. So here's the first graph we looked at. So April 2020, that's this kind of time here. April 2020, when the green line and the red line are essentially superimposed on each other. Remember, the red line is excess deaths, the green line is the use of midazolam. So April 2020, there was a 98.8% in excess deaths increase. In other words, virtually double the amount of excess deaths. The other peak here, which is in, this peak here is January 2021, 29.2% increase in excess deaths. Now this represents the excess deaths of 43,796 individual human beings. This represents, for the month, an increase in 16,546 in the number of excess deaths. This is quite incredible. The other thing that struck me about this, as well as the failures in national organisation, national reporting, national data, national governance, and arguably in nursing and medicine, is the failure of the coroner system. Now, coroners have been used in the United Kingdom since, from memory, I think it was Richard I, Richard the Lionheart. So we're talking about 1190s, I guess. 1190s, when the coroners were first used in this country. And this has been a system adored for nearly 900 years, because you know that if someone bumps you off, if someone bumps me off, okay, I'll be dead. But the coroner will look into it and find out if foul play has been involved. And I must say, I'm deeply unimpressed with the coroner system in the UK. It just doesn't seem to be flagging this up at all. I really find it hard to explain. Now, I've worked with coroners. They're really good people. So quite what is going on here, it's really hard to explain. Let's look at some more of the graphs to get a bit more data here. So this is UK monthly all-cause total deaths and excess deaths. This is excess deaths here in red, and this line is 0. It's the 5-year average along that line there. Here we see the excesses from April 2020 and from January 2021. Monthly all-cause total deaths. So we see that, again, there's a good match there. There's a good correlation, especially between these spikes here, April 2020 and January 2021, but pretty good correlations further on. That one correlates with that one. That one correlates with that one. So we see that the excess deaths are basically the all-cause deaths are linking up with the excess deaths. That makes sense. Now, this is the UK monthly excess deaths percentage from the baseline, and again, the baseline here is 0. What we see here is these are sigma values, the standard deviation. So we see that this great big peak here was actually 20 sigma, 20 standard deviations from the norm. Absolutely incredible. And no question that you're dealing with serious anomalies in the data there. That sort of thing doesn't happen by chance. Now, this is also given in the paper. So we see early on, so again, monthly new COVID deaths, or what were attributed to COVID deaths. So official data, these are COVID deaths. Now, if it's true that these are COVID deaths, and of course, the argument here is it's not. The argument here is a lot of these deaths are attributable to excess use of midazolam and morphine. And of course, remember, 2020 is before the vaccine rollout. If it is that these were COVID deaths, then that gives an infection fatality rate of 24.3%. In other words, 1 in 4 of people who were getting infected with COVID were dying. I don't believe that. This has got to have some other cause, and that cause, presumably, according to this paper argues very well, is that a lot of these deaths were caused by iatrogenesis. Because later on here, the infection fatality rate was down to 0.18%, which probably much nearer the mark, with the average age being in the 90s. So I simply don't believe that the infection fatality rate fell from 24%, 24.3% to 0.18%. There's got to be other explanations for that. Okay, it's partly due to testing, but testing was always a problem. Not that many people were tested in 2020. More tests became available in 2021. But even accounting for that, I think part of that, I agree with Wilson Tsai, that part of that is the use of morphine and midazolam. Now, further evidence here. This is items of midazolam, 10 milligrams in 2 ml solution for injection ampules by all regions. So this shows it happened. I think that's London there, the one with lower rates. But this is different colours here for different regions in the UK. In other words, everywhere. This same pattern happens everywhere. So we see that this meets Bradford Hill criteria. It's reproducible in every area that you look at. It's the same. It's the same all around the country. The same overall shape of the graph all around the country. UK excess mortality by region. Again, these are different regions here, looking at excess mortality. I'm not going to decode all the different colours in the regions, but we see that this phenomena occurred everywhere, as of course the government guidelines and the NICE guidelines, the National Institutes for Health and Care Excellence guidelines, were followed all over the country. So again, we see a lot of consistency between areas. So this is with 1 month lead taken out, as we saw. That gives us the exact overlap. The real data is actually looks like this. So we see that the excess deaths in red are actually following a month behind the distribution of the midazolam. And to me, that is just further evidence. I mean, look how neat that is. You know, that just slides into that one, and that one, that January 2021 one, just slides into that one. You know, the peaks in the red occurring just after the distribution of the midazolam. And of course, in practice, midazolam was often given with morphine, making a double whammy. Here we see other regions. What's this? This is UK monthly midazolam injections with 1 lead month and so-called COVID deaths. That's right. So again, adjusted for the month, but the COVID deaths, coincidentally, in red, the COVID deaths were highest when the midazolam was at its highest. So green is more midazolam, red is more deaths. Look at those and tell me you don't see a connection between those two. I do. And as we've seen, it's applicable to all areas of the country, giving us some degree of reproducibility. So England, monthly midazolam injections, 1 monthly, that's when it's corrected. We see the overlap again is there when it's corrected for the 1 month delay. This is the data from London. Same. Smaller numbers, of course, because it's just London, but it's the same pattern. This is the data from Northwest, UK Northwest. Same, basically. This is data from Southwest. Basically the same. We're seeing it's the same in all areas, which really makes quite a strong case, I think. Yep. So the authors say, well, I'll show you one more thing just before we do that. I've got my overhead working. Yeah, there we go. This is the excess deaths here. So these are the excess deaths. 2020, 76,000. Was that due to COVID being so dangerous? Well, 2021, when the vaccines came in, they went down. 2022, when the vaccines had well and truly kicked in, 45,000. Or at least that's what the government would like you to believe. But as we've just seen, it correlates with midazolam. So if it is the case that this 76,000 plus deaths were, a large chunk of those were caused by giving midazolam and morphine, that means the reduction in deaths in 2021 was because less midazolam and morphine were being used. And by 2022, much less was being used. That would equally well account for the reduction in deaths that we see. So this idea here from the deaths that COVID is very dangerous, well, this interpretation, which is disputable, according to the author, justified politically the declaration of emergencies and all public health measures, including masking, lockdown, etc. So all of those terrible things that happened during the COVID pandemic, allegedly because COVID was such a deadly disease, could have been implemented because midazolam and morphine is such a deadly combination. And I know for a fact midazolam and morphine is a deadly combination. It wasn't me that gave the injection, but a colleague of mine once gave some intravenous morphine without midazolam, just the intravenous morphine, correctly, for pain, given correctly. And then to her consternation, the patient stopped breathing. Just stopped breathing. Now, it was fine. She pulled the emergency buzzer, we went in, we ventilated the patient, we gave naloxone, Narcan, and the patient was 100% fine. But I've actually seen a patient stop breathing just with morphine. If you give morphine and midazolam together and someone's already got a respiratory infection, well, you don't need much more than Boy Scout first aid to realise that that's a dangerous combination. Sadly, it wasn't realised. The evidence of this vaccine effectiveness, the author says, Dr. Sai, was illusory due to incorrect attribution of the 2020 spike. So that 2020 spike there, as we see, for example, in this data from the Southwest, not COVID with a 1 in 4 infection fatality rate, but quite potentially caused by morphine and midazolam mixed together. Meaning the whole thing could be based on this misinterpretation of data. Now, there's a bit of a postscript to this talk. I'm going to just read a little bit now from what the authors say. Despite advances in modern information technology, the accuracy of data collection has not advanced in the United Kingdom for over 150 years. Quite incredible. And that's based on the work of this gentleman here, Alfred Russel Wallace. Great scientist. The media is always talking about him for being the co-discoverer of the theory of evolution by natural selection with Charles Darwin. Great scientist, naturalist, and a kind of guy I would really like to have had a couple of pints of beer with, I must say. Sadly, he died in 1913. Anyway, the authors go on to say, because the same problem of erroneous data entry found then are still found now in the COVID pandemic. So the same problems discovered by Alfred Russel Wallace in the 1880s and 1890s were still there in the 2020s, not only in the UK but all over the world. We have independently discovered the same UK data problem and solution for assessing COVID-19 vaccinations as Alfred Russel Wallace 150 years ago, and investigating the consequences of the Vaccine Acts starting in 1840 on smallpox. So what Alfred Russel Wallace did after he discovered the theory of evolution by natural selection, or basically natural selection survival of the fittest with Charles Darwin, he then went on in later life to study the 1840 smallpox Vaccination Act. So he went on to do that. And this is all in a really quite interesting book here. I can show you it here. This is it. It's available. You can look at the whole text. It's one of those really cool ones where you can turn over the page and read the whole book. Thankfully by the Wellcome Foundation. So the whole thing is available. And what we find is, and I didn't know about this, I must say, that Alfred Russel Wallace found the same deficits in data after the Smallpox Vaccination Act of 1840 and later acts in times we'll look at in a minute. 1853, I think the next one was, making it compulsory. The same data problems are still there in the UK, that you can't narrow things down. So what Wilson decided, he said, I'm going to use the Wallace method, which is looking at this megadata, looking at the whole thing, which of course in my view is a much better way to do it. So Alfred Russel Wallace, as used by Wilson Psi, it's very clever what Wilson's done here, I must say. Alfred Russel Wallace said this: having thus cleared away the mass of doubtful and erroneous statistics, ringing any bells, depending on comparisons of the vaccinated and unvaccinated in limited areas and selected groups of patients, well, we still don't have that data. It's not released by the UK government, unless you work for a pharmaceutical company, of course, in which case it is released. It's not released to the hoi polloi like you and me, or more importantly, to our statisticians like Dr. Clare and Professor Fenton, who would love to analyse this data. Alfred Russel Wallace goes on in his publication of whenever it was, 1880 or something, 1890, something like that. He goes on, do check this out for yourself. It's really good fun. You can just click over the pages. We turn to the only really important evidence, those of mass national experience, is what he said. So really quite incredible, working in the 1880s and 1890s after the 1840 Smallpox Vaccination Act, which provided free smallpox vaccination for the poor. Now, if you don't want to hear this history, then click off at the main part of the video is done. I just found it so interesting, I just had to go on making some notes on it. So free smallpox vaccination was made available to the poor in 1840. In the same act, of variolation was banned. So variolation was... in variolation, they actually gave some smallpox pus. They actually gave someone the disease, which is a really bad idea. So variolation, variola, smallpox, that was banned. But it was made, but the smallpox vaccination apparently was made compulsory in 1853 and 1867 acts. I wasn't aware of that. So why was he interested? Why was Alfred Russel Wallace interested? But in Leicester, there was anti-vaccination demonstrations in 1885. I wasn't aware of that, but it rings bells, doesn't it? There was growing public resistance to compulsory vaccination in 1885. And Wallace had increasing involvement in social reforms and statistical arguments. So his interest in social reform, his skill in statistics, put him in the ideal position. And again, we've got people like that. Professor Fenton would meets both of those criteria. He has the expertise. He has the interest in social welfare. Why don't the government give him the data? Is an open question. Statistical critique of vaccinations. So government data on smallpox mortality trends before and after compulsory vaccination. This is what he looked at. He looked at mortality trends before and after compulsory smallpox vaccinations. He took into account the case mortality rate. Just like history really repeats itself, doesn't it? Or it rhymes at least. Then he looked at vaccination versus sanitation effects. Because, of course, sanitation then was improving dramatically. So was it that people were being vaccinated, or was it because sanitation was being improved? Now, I'm not giving answers to this. I'm not saying it was one or the other, because this is still hotly debated today. But he looks at mortality trends before and after each act in 1853 and 1867. And he wrote a paper called 45 Years of Registration Statistics, proving vaccines to be both useless and dangerous. So 45 years of registration statistics proving vaccination to be both useless and dangerous. Not the case I'm making, I'm simply saying what Alfred Russel Wallace published in 1885. And then this book that we've been looking at here, which you can read for yourself. This is Vaccination, a Delusion, Its Penal Enforcement, a Crime. Published in 1898. And he also made contributions to the Royal Commission on Vaccination in the from 1890 to 1896. So Wallace argued this: declining smallpox mortality was due to improved sanitation, not vaccination. In other words, Wallace argued it wasn't the vaccines that were saving people's lives, it was improved living conditions. And this is true today. Very often it's how you live, your diet, your exercise, your lifestyle, what drugs you take, more importantly what drugs you don't take, like alcohol and tobacco and things, that decide how healthy you're going to be, as opposed to just taking a pill for everything. So Wallace argued that declining smallpox mortality was due to improved sanitation, not vaccination. That was his argument. Official statistics were misinterpreted or biased, he said. So this is Wallace in the end of the 19th century, 150 years ago, saying official statistics were misinterpreted or biased. And then Wilson Sy saying we still have basically the same problem in the 2020s. Couldn't make it up. Wallace argued that compulsory vaccination was unjust. He argued that revaccination did not reliably prevent outbreaks. With COVID, we know that's true. It wasn't preventing transmission to any extent at all. So he was arguing that vaccination did not reliably prevent outbreaks. And these views, we should note, are strongly disputed then and now. Wallace had a strong distrust of medical authority. But he did believe in statistical reasoning, social reform, opposition to coercive government measures, and the primacy of environmental and sanitary conditions, and I would add lifestyle conditions, in health. This is a guy who died in 1913. What a guy, eh? Love to have had a pint with him. Fascinating. Always good to learn lessons from history, which doesn't repeat itself, but it sure as heck does rhyme. The serious point here is people who lost relatives, especially in those peaks in 2020 and 2021, really can't have closure because they don't know if their relatives died of COVID, which some did, or of midazolam and morphine, which I suspect a lot more did. Now, my understanding is that medical records in the UK are kept for 7 years. So time is ticking. So my appeal would be that health authorities and governments anonymise this data, which they can do, and release it for our statisticians to analyse. Then we can work out if indeed morphine and midazolam caused mass fatalities. Then we'll know for sure. To me, the evidence is currently very convincing. Read this paper, I think you'll agree. But that data needs to be released. Now, given that we've got our current government in the UK for another 3.5 years, the worst government of my lifetime, I would say, and I'm not even that political, but they're just terrible. And they've refused to release this data. I think a lot of these records are going to be no longer available within 7 years by the time we have a governmental change. That means a lot of people will never know why their loved ones died. A situation which I consider to be appalling. Bit of a long video today. If you got to the end, well done. Thank you for watching. Just so interesting the way that Alfred Russel Wallace had the same problems and came to very similar conclusions. I wish I'd known more about his work 5 years ago. But there you go, we live and learn. At least some people do. Thank you for watching.